Welcome everyone to today's Top Science Press Conference for the American Academy of Neurology's Sports Concussion Virtual Conference to be held this coming weekend, July 31st and August 1st. I'm Renee Tessman, Senior Manager of Media and Public Relations at the American Academy of Neurology. If you are just logging on, please note that there are some key directions in the chat feature. Today's featured presenters are the co-directors of the American Academy of Neurology's Sports Concussion Virtual Conference, Dr. David W. Dodick of the Mayo Clinic in Scottsdale, Arizona, and Dr. Brian W. Hainline of the National Collegiate Athletic Association, more commonly known as the NCAA, in Indianapolis, Indiana. Both are top experts in concussion and traumatic brain injury, and they will be presenting their choices for top science at this year's conference. Good morning, Dr. Hainline.
Thanks, Renee, and really glad to be here, everyone, to discuss three really exciting abstracts, which is a prelude to our virtual conference this year, which is the American Academy of Neurology Sports Concussion Conference. So welcome, and looking forward to some good discussions and good questions.
Thank you, Dr. Hainline. Good morning to you as well this morning, Dr. Dodick.
Good morning, Renee. Thank you, and thank you to the American Academy of Neurology for organizing this. I'm looking forward to it, and I want to thank all of the participants from the media for being here today.
Wonderful. We're happy that you're both here with us this morning. We sent out abstracts this morning via email, so journalists, if you have not received them, please let us know in the chat, and we will email them to you after the press conference. Please note this press conference is being recorded and will be posted on the American Academy of Neurology's YouTube channel. As I read the names of the abstracts, you will see that there is a name and email address for the lead author of each abstract. This is so you may reach out to the authors via email after the press conference if you wish to request an interview. So let's begin. The first abstract is titled, Age of First Exposure to Collision Sports Does Not Affect Quality of Life Outcomes in Community Rugby Players. The lead author is Thomas Buckley, PhD, and his email address is tbuckley@udel.edu. Dr. Hainline, please summarize the abstract and its findings. Then you and Dr. Dodick can discuss why you chose this abstract.
Well, thanks, Renee. And this is another in a series of studies that really is truly important. And Dr. Buckley is a well-respected concussion researcher. So this topic has really gained significance, especially since a paper was published by Dr. Alasko and colleagues in 2017. And that paper looked at former NFL players, over 200 players, and even though it was a convenient sample, it did demonstrate that there seemed to be an adverse outcome if you started playing football before age 12 versus after age 12. And importantly, in that paper, they said that because this wasn't a longitudinal study, we shouldn't make policy changes just based on that alone. But subsequently, there have been other papers, some that have confirmed that, some that have actually said, well, age at first exposure doesn't make a difference. And so the question is, how long do we follow individuals out? So there's been a collegiate paper that was from the NCAA Department of Defense Care Consortium, which showed that there wasn't a difference in collegiate athletes. So in this study, Dr. Buckley and colleagues, they looked at over 1,000 rugby players. They looked at the age at first exposure before age 12 or after age 12 in contact collision sports, not necessarily just rugby. And they followed them out. And importantly, in this study, the average age was about 31 years plus or minus 11 years. And why is that important? Well, you're extending beyond the collegiate age, and you're getting into the age where you may be seeing some individuals who could have neurodegenerative diseases, although in the NFL study, we were really looking at individuals over the age of 50 and so. So this study demonstrated that there were no differences in a number of measures, really neuropsychiatric measures, especially looking at mood and somatization, mental changes. And so it's an important study. It takes us into that ongoing debate. Does the age of first exposure make a difference? What this study didn't demonstrate, and really what no study has done well, is to understand, well, what happens at that age of first exposure? What is the type of repetitive head impact that occurs? What is the type of concussion manifestations that occur? That's what's really key, and we need to get that longitudinally. But we take this study, and even though it's not definitive, it really adds to the healthy debate of what we need to do with youth sport and how do we really oversee youth sport in a manner that's reasonable.
Dr. Dodick, you need to unmute yourself. There you go.
You think after all these Zoom meetings over the past 6 months, I would have gotten this by now. Thanks, Brian. That was an excellent summary. And as you said, the younger age of first exposure, before the age of 12 in particular, has been associated with an increased risk for impairment, both subjective and objective, in neuropsychiatric, neurobehavioral function, as well as cognitive function, predominantly in former American football players. This is an important study and certainly adds to the body of evidence, but it also adds to the conflicting body of evidence that we have. So why the discrepancy between this study and previous studies that have shown that age of first exposure does have an impact long term? Well, one thing is, as I alluded to, the previous studies were predominantly in American football players, and this is in a rugby athlete population. So they're two different sports, and it's not clear whether the long-term risks are different between the two different sports. That's one thing. Secondly, you have to look at what outcome measures were used to determine outcome and how were they used. So in this study, all of the completed questionnaires were done online without direct patient contact, whereas previous studies that looked at long-term neurocognitive impairment were done with direct patient contact and objective, the completion of objective neuropsychological testing. I think third, and as Dr. Hainline mentioned, if you're going to look at long-term outcomes, you have to look long-term. And so this did extend the age, as Dr. Hainline said, beyond the collegiate up to the age of about 30, 31 years. But, as he also mentioned, the studies that did show a difference in terms of the age of exposure influencing long-term outcome looked at individuals around 50, 51, 52 years of age on average. And so maybe that's the reason why you have to look longer term to see whether or not there are long-term impacts. I guess another reason was that the measures here looked at quality of life and somatization and mood or behavioral regulation. In the past, in the studies that did show an impact, there were measures of depression, neurocognitive, and executive functioning. So executive functioning meaning attention and working memory and planning, reasoning and problem solving. And as well as apathy, which wasn't assessed in this study. Apathy being sort of a lack of interest, a lack of enthusiasm, a lack of concern. And there were significant differences in individuals who began playing before the age of 12 with regard to those particular domains. Importantly, in those previous studies that did show a difference, the effects seemed to be independent of the level of play, so whether you reached college or whether you reached professional leagues, and duration of play. It didn't really matter how long you actually played. So, and as Dr. Hainline said, we're not exactly sure, because of the conflicting evidence, what is true and why there would be a difference. But we know that between the ages of about 8 and 12, there's a lot of maturation that's occurring in the brain. Cortical thickness increases. There's maturation of important structures in the brain like the hippocampus and amygdala, which control emotion and memory. And there's also myelination. So the brain is insulated during that period of time. So it's possible that, if a brain is injured below the age of 12, it could affect the maturation of certain brain structures. And indeed, previous studies have shown a difference in the age of first exposure and maturation or alteration of the structure of certain brain regions. So it's a complicated area. It's a really important area. I think this abstract is really interesting. It certainly adds to the body of evidence, but I agree with the author's conclusion that later life potential consequences of repetitive head injury in rugby players still remains to be elucidated. And what we need is a prospective long-term study that goes out to at least the age of 50 or more to see whether there are any long-term effects.
Yeah, great point, David. And so, that study is taking place. The NCAA Department of Defense Care Consortium is actually planned for more than 25 years. And we're actually going to be not just looking at NCAA athletes, but former cadets. So at the 4 service academies, and we'll be able to differentiate what happens in the military career versus a former student athlete career. And it is going to take time. So, you know, David, when we're doing this conference 20 years from now, we'll have that definitive data and we'll be able to talk about it. But also importantly, you know, because there is conflicting evidence, what do you do about that? And USA Football, I think, made a very, very important decision recently, in that they changed the rules of engagement for youth football. They developed something called the football development model, which is part of the American development model. And so you need to be engaging in activities that are developmentally appropriate. Yep. And just as David was saying, well, at age 8, you know, the brain myelination has a certain pattern, but at age 8, you know, from a neuromuscular point of view, might not make sense to have a helmet on your head because you can barely control your head even without a helmet. And so that's what's really taking place now, is developmentally appropriate activities. And so we're seeing a paradigm shift while we're still studying this issue, this very important issue long term.
Yeah.
Okay, thank you both, Dr. Dodick and Dr. Hainline. We will now take questions from journalists. If you have a question, please type your name and your affiliation, your publication, into the Q&A feature found that if you hover over the bottom of your screen. My colleague, M.A. Roscoe of the AAN, will call on you and ask you to unmute yourself when asking your question. M.A., do we have any questions at this time?
I do not see any questions at this time, Renee, but if you do have one, please ask Dr. Dodick or Dr. Hainline in the Q&A function, and I'll be happy to pass it on.
Okay. Thank you very much, MA, and we will now move on to the next abstract. The second abstract is titled, Do Learning Disorders Impact Clinical Measures Following Concussions? The lead author of that abstract is Matthew Stokes, MD, and his email address is mathew.stokes@utsouthwestern.edu. Dr. Dodick, could you please summarize this abstract and its findings, and then you and Dr. Hainline can discuss why you chose this as top science.
Sure, Renee, thank you. So this study was an interesting study. It had as its objective the evaluation of differences in clinical testing following concussion between adolescents who did not have a history of a learning disorder and those who had a history of either dyslexia or attention deficit disorder or attention deficit hyperactivity disorder. And by way of background, you know, learning disorders such as ADHD can certainly affect baseline neurocognitive testing. We've known that. But the effect that ADHD has on other clinical measures is less well understood. And there's also limited data that exists on the effects of dyslexia on these measures. So in this study, data was prospectively collected from a cohort of over 1,000 individuals between the ages of 10 to 18 years of age who were participating in the North Texas Concussion Registry. And these adolescents experienced a concussion within the previous days and then were enrolled and assessed for whether or not they had a history of a learning disability, either dyslexia or ADD or ADHD. So they included a total of almost 1,300 actually, 58 of whom had dyslexia, 158 had ADD or ADHD, and 35 actually had both. So in the dyslexia group, they found that they had impaired saccadic eye movements, and in the ADD, ADHD group, they had higher impulse control scores as well as higher depression and anxiety scores. And the authors concluded that participants with dyslexia and or ADD or ADHD had worse scores on commonly used concussion clinical measures, including the impulse control measure on the impact test, as well as saccadic eye movements on the King-Devic test, and depression and anxiety screening tools. And that understanding these differences in these groups will help healthcare providers in their evaluation of these athletes and assist in counseling them and their families regarding their risk of injury. So this is important because there is now a growing body of evidence which demonstrates that adolescent and collegiate athletes they're more likely to have a history of concussion, and they're more likely to have a history of multiple or repeated concussions, and they're more likely to have symptoms when undergoing baseline testing. And it's important to understand and recognize that when you're doing baseline testing in someone who has a developmental learning disorder. There's also evidence that collegiate athletes with ADHD, whether or not they're on medication for their disorder, they can take up to 3 times longer to recover from a concussion. They exhibit greater decreases in cognitive skills like verbal memory, thinking and learning skills, visual motor speed that controls hand-eye coordination. And they also have a greater increase in the severity of symptoms. So symptoms that exist in both groups, for example, they tend to be more severe in the group with ADHD. So I think the upshot of this abstract is, for us clinicians, ascertaining the presence or absence of ADD, ADHD, dyslexia, and other developmental learning disorders in those who are participating in activities and sport, especially where there's a high exposure risk of head injury, is really important, especially when trying to interpret the results of baseline testing, the results of post-injury testing, decisions on when to return that individual to play, and when assessing for the individual and their families the risk of long-term repeated concussions as well as the risk of long-term adverse outcomes. So I think it really is an important study, and it behooves us all to pay attention to this when assessing these athletes.
Yeah, great summary, David. And first and foremost, where we are with concussion today, it's still a clinical diagnosis. We're starting to get some objective biomarkers, but really 99% of concussions, how it's diagnosed today, is clinically. So this is important for clinicians to understand that those athletes with ADHD, with learning disabilities, they manifest differently with concussion. Their scores are going to be different, and that has to be taken into account in your decision making. It also, as Dr. Dodick mentioned, that athletes with ADHD, that they are going to suffer with more concussions, may have more prolonged recovery. So that's part of informed decision making, helping these athletes to understand that they may be at more risk. And it brings us to another really important point. Concussion is not a homogeneous entity. It's a brain injury. It can manifest in multiple parts of the brain. And the way the brain is from a premorbid point of view or comorbid point of view can actually influence the manifestation of concussion as well. So all of these things need to be taken into account. And maybe one last point, and it ties into the abstract we're going to discuss next, the attentional deficits may be important in sustaining an injury in and of itself, and it may make these individuals more susceptible to certain kinds of injuries, including head injuries. So all of this is an evolving body of research, and it's helping clinicians make better decisions and to understand athletes who may manifest differently. So thanks for that summary, David, and agree, it's a great study.
Thank you, Brian. Well said.
All right, we will now take questions from journalists. If you have a question, again, please type your name and publication into the Q&A feature found over the bottom of your screen, and M.A. Roscoe will call on you. M.A., do we have any questions?
Renee, we don't have any questions right now, but I do want to thank Dr. Matthew Stokes for joining us today, and he was the author of that last abstract.
Wonderful to have him in the audience. That's great. All right, well, thank you, everyone. Let's move on to the third abstract. The third abstract is titled No Sex Differences in Risk for Lower Extremity Musculoskeletal Injury in Concussed Amateur Rugby Players. And the lead author is also Thomas Buckley, PhD. Dr. Hainline, could you please summarize this abstract and its findings, and then you and Dr. Dodick can discuss.
Well, thanks, Renee. And again, hats off to Dr. Buckley, who has been really producing some really important information about concussion and important emerging information to help us understand this better. This is a really interesting topic that I think hasn't gotten the attention that it deserves. So there's an evolving body of literature that individuals who have suffered a concussion, that they're more likely to have lower extremity injuries. And it's not when they're still symptomatic. This is up to 1 or 2 years beyond the period of concussion. And the literature to date has primarily focused on men, and so the risk hasn't been as certain in women. Now, why this study is really unique and so interesting is rugby is, well, I think it's the only contact collision sport that I know of where the rules of engagement are exactly the same for men and women. So this is a really interesting population of over 1,000 individuals. So you don't have American football where you can control and or compare men and women. And in another really famous or contact collision sport, lacrosse, well, it is a contact sport for men, but it's not in women. The rules are actually different. So that's what makes this so interesting. And what Dr. Buckley found is that there is an increased risk of musculoskeletal injury that is equal in men and women post-concussion. Now, what we don't know from this study is for how long that timeline lasts. We don't know the degree to which individuals may have had any lingering symptoms because it was retrospective in nature. But in speaking to Dr. Buckley, he does believe that this did extend over time. It wasn't in the acute post-concussion period. So that's important because it tells us, well, what really is going on? Why would someone who's had a concussion, they've seemed to recover symptomatically, but they're still at risk of a lower extremity injury? A lower extremity injury, by the way, which might have lifelong implications that are perhaps worse than a concussion. If you can recover from a concussion, that's fine. And we certainly aren't advocating to get concussions. And we know that there are risks long-term, possibly for neurodegenerative diseases if you've had multiple head impacts. But what's going on in the 1 or 2 year period? Well, this has been looked at by other authors. There may be a dual mechanism or dual task neuromuscular control or facilitation that might be impaired long term. It may have to do with attentional deficits or maybe with the motor proprioceptive deficit. So what are the sensory signals coming in and how is that interpreted in the motor system? And so it's a hugely important issue, and it ties into another abstract which is going to be released for a sort of a PR point of view, and that had to do with that there were impairments in driving reaction time for individuals after a concussion. So I think this is really important, David, and I hope that it's going to spark some research or for some tools to look at objective measures of attention, balance, proprioception that we need to look at, especially in the lower extremities, because this is now a theme and we need to pay attention to it.
Yeah, it's a beautiful summary, Brian. As you said, what's unique about this is Dr. Buckley was able to show that the risk is equivalent in both males and females, which to my knowledge, that's the first time this has ever been shown. We've known now that there are numerous previous reports on the increased risk of musculoskeletal injury in athletes who return to play after a concussion, both in professional and collegiate athletes, and in men and women's sports, by the way, women's basketball, women's lacrosse, women's soccer. But we never knew that the potential for that injury was equal in both groups. So it really is a very nice and unique study, which makes a novel contribution to the literature. I'll also echo what Dr. Hainline said, and that is that I'm glad that we have the opportunity to highlight work like this, because although there's been several reports highlighting the musculoskeletal risk of people who were concussed and returned to play, it's really gotten very little media attention. So I'm glad we're able to highlight this today. As Dr. Hainline said, because these risks continue to persist well after the time that symptoms have resolved, it really highlights for clinicians how careful we have to be in assessing that risk, because in some previous studies, that risk, up to 50% in some studies, can experience a musculoskeletal injury after returning from a concussion. And it seems to be due to persistent, perhaps subclinical effects of concussion on both neuromuscular control as well as neurocognitive function. For example, the function of the motor cortex in the brain that controls movement has been shown to be impaired from a neurophysiological standpoint well beyond the time after symptoms have resolved. So perhaps that is at play here. We've also known that there's persistent alterations in neurocognitive function. And when you combine those two, it may impair an athlete's ability to interpret environmental cues, to anticipate the actions of their opponents, and for them to generate the appropriate neuromuscular response to perform an athletic maneuver or to avoid or dodge an opponent or to brace for a collision. So because they're subtle and subclinical, they're not easily detected in the way that we currently evaluate athletes, both after an injury as well as at baseline. And it really highlights, I think, Brian, the shortcoming of the guidelines that we have and the need to actually incorporate new tools to be able to assess these subclinical deficits in neuromuscular control and in neurocognitive control that could impair an athlete's ability to attend to their environment and respond quickly. Because as you said before, these athletes need to make split-second decisions on the field. And if there's a delay in that, they may not be able to avoid injury. So I think it behooves us to now begin to validate tools that adequately assess these subclinical deficits and incorporate them into our baseline testing and our evaluation of these athletes, both before and after a concussion.
Yeah, well said, David. And you know, when you talk about the neurophysiology, so again, I'm going to bring back the NCAA Department of Defense Care Consortium, but in that we're trying to differentiate in this long-term prospective study, what's the difference between clinical recovery and neurophysiological recovery? And we need these objective biomarkers. We're trying to get up by way of brain MRI, you know, functional, qualitative, quantitative MRI, and with other sorts of objective biomarkers, blood-based biomarkers and neurophysiologic biomarkers, but we don't have that right now.
No.
And again, it's a plea to all of the scientists out there. Let's also develop some tools that really look at neuromuscular facilitation, because something is going on and it's something that's important. And when you're talking about split-second decisions in an athlete, you're talking about 3 milliseconds that can make a real difference. That's certainly the difference between being in the zone and choking. And it also can be the difference between making a split-second decision in terms of when you're going to cut or not cut. So yeah. Let's keep drumming this up, because this is really, really important research.
Yep. And I think it behooves us to be asking athletes, because they know themselves, they know their bodies. They're very tuned to that. And so subjectively, if they feel like they're not firing on all cylinders, or they're not quite the same, even though we can't detect it in the office based on a neurological examination, we need to be paying attention to that, and we need to be counseling the athletes, making them aware that this is a risk, and that perhaps we need to keep them out until such time as they do subjectively feel like they're right back to normal.
Yeah, I think that last point, I just want to amplify on that, David, just listening to the athletes. And I'll go to another domain where an athlete says, you know, I just feel like I'm a little weaker in my right leg or in my arm. And we, you know, the neurologists, we do the motor testing, and you know, it's like not 5/5, it's like 10/5, because they're so strong and they're kind of picking us up with their arm. But if they notice just that little bit of a functional difference, we must take it seriously, because it's real.
Yeah, absolutely.
Well, thank you both, Dr. Dodick and Dr. Hainline, for summarizing that abstract. We appreciate that. And Dr. Hainline did refer to another abstract on driving reaction time. That one can be found on AAN.com/pressroom. That is another sports concussion virtual conference abstract that we did feature in press release. So we will now take questions from journalists. MA, do we have any questions?
We do not, and I know for sure who does not have a question, and that's Dr. Thomas Buckley, the author of abstract number 1 and number 3, who joined us today. So thank you, Dr. Buckley, for joining us in today's press conference.
Thank you, Dr. Buckley, as well. And journalists, we did include the names and email addresses for both Dr. Buckley and Dr. Stokes in these slides. If you missed them and need them, you can reach out to MANI. Our email addresses are Renee Tessman, rtessman@AAN.com, and MA Roscoe at mroscoe at AAN.com. So Dr. Dodick and Dr. Hainline, I would like to thank you as co-directors for the 2020 AAN Sports Concussion Virtual Conference. We really appreciate you sharing your expertise with us today.
Well, thank you, Renee, and I want to thank you and your team and the American Academy of Neurology for making this possible, and thank the participants for attending. And also thank you to our authors who actually were in attendance as well for such careful research and such important contributions to this field. So thank you.
Yeah, I agree. Going to echo Dr. Dodick's sentiments, and I'm really happy that the AAN is continuing with this sports concussion conference. And, you know, we kind of forgot about concussion in the age of COVID-19. And it's honestly, David, it's a little refreshing to be speaking about concussion again, you know, rather than COVID-19 16 hours a day. So, yeah, but anyway, thanks everyone, and thanks for joining.
Thanks, Brian. Thank you.
Thank you both again, and thank you to the journalists as well who joined us and are in attendance today for our Top Science press conference. For more information about the American Academy of Neurology, you can go to AAN.com. Again, that's AAN.com. Have a wonderful day, everyone. Thank you.